Thank you everyone for attending the afternoon session titled New Data from the Latest Clinical Trials. On behalf of Graham Foster from the UK and myself, Dave Nelson, we welcome you and look forward to 4 great talks. These talks are going to be about 8 minutes. We'll have a couple of questions after, and since the sessions are behind, we're going to try to keep on time. So the first talk is going to be real-life results of triple therapy with a combination of sofosbuvir-pegylated interferon and ribavirin for Egyptian patients with hepatitis C, and we welcome Gamal Esmat.
Thank you very much. It's my pleasure to be here, and thanks for the organizing committee for accepting this work to be as an oral presentation. This is the list of the authors and their affiliation. And in fact, we know the problem in Egypt with high prevalence of HCV, and also more than 90% of our patients are genotype 4. This is the national survey that was done in 2008, and you can see that in 2008, the prevalence of HCV antibody was about 15%. This national survey was done on residents from 15 to 59 age group. But the good news that we did another national survey in 2015, and this is from 1 to 59 years old. And the good news is that the antibody dropped to 6.3 and PCR dropped to 4.4. So I hope next year when we have all this data published, we'll not still say that Egypt had the highest prevalence of HCV all over the world. I hope this will be changed. By this also, we still have the largest burden of HCV infection, and the infection is predominantly genotype 4. Triple therapy for sofosbuvir-pegylated interferon and ribavirin has shown very high sustained virological response. All of us know the neutrino study in clinical trials that include HCV genotype 4 patients. Its introduction in late 2014 in the National Treatment Program marked the beginning of the new era of HCV therapy in Egypt. The real-life results of this therapy for HCV genotype 4 is not known till now. Here we can see the trials for the neutrino study saying that for those who are naive, if they received pegylated interferon-ribavirin and sofosbuvir for 12 weeks, the response will be about 96%. Sofosbuvir and ribavirin 24 weeks for those who are naive will be about 100%, and it dropped to 86 for those who are experienced. Gilead Access Program reduced cost drastically, so we can start the national program for treatment of HCV using the sofosbuvir by October 2014. And we have 2 regimens for the treatment at that time. One of them we called it triple therapy, sofosbuvir-pegylated interferon and ribavirin for 12 weeks for those who are eligible to interferon. And the other is sofosbuvir-ribavirin 24 weeks for those who are ineligible to interferon. When we started our program, more than 700,000 patients registered for evaluation, and we already evaluated more than 200,000 patients. 40,000 of them have F3 and F4, and they were selected for treatment. They are about 20% of the patients who have been evaluated, and 15,000 patients started treatment. 1/3 of them started by triple therapy, and 2/3 by dual therapy by sofosbuvir and ribavirin for 24 weeks. When we send this abstract, we have data for sustained virological response. We have data for HCV PCR after 12 weeks of stopping treatment for 500 patients. But now I am demonstrating the data for about 900 patients, because by the end of 2014, we have 899 patients received triple therapy, and they were included in this analysis and have currently reached 12 weeks after the end of therapy. When we look to the data that we have about 900 patients, and 6 of them have discontinued the treatment. Eight discontinued the treatment, 4 of them after 4 weeks, and 4 of them after 8 weeks of starting treatment. And this is because we have severe anemia for 2 patients. We have 5 hepatic decompensation, and we have 1 mortality due to bleeding esophageal varices. For those who finished the treatment, we have end of treatment response 96%, and for those who have reached 12 weeks, we have sustained virological response 86%. This is the figure for this, and it is more illustrated that the sustained virological response is about 86, and we have relapse 11%, and the discontinuation, as I said, for 8 patients, and 27 patients have positive at the end of treatment. When we compare between those who have sustained virological response and no sustained virological response, there was no difference as regards the sex or age or the body mass index, the presence of diabetes, but there is a trend for those who have treatment experience before. Their response is less than those who are naive, but this is only a trend. And when we look to the lab investigations, we'll find that patients with non-sustained virological response have elevation of ALT more, elevation of AST more, and elevation of alpha-fetoprotein more than those who have sustained virological response. And also they have less albumin when we compare to those who have sustained virological response. But going to multiple regression and confidence interval, we found only the albumin which has this predictor of response. So those patients with low albumin response less to this triple therapy. And when we compare between the different pattern of response, all patients, the response is 86%. For those who have experienced treatment, 83%, cirrhotic 84%, those who have esophageal varices 80%, those who have splenomegaly 85%, and those who have FIB4, denoting that they have cirrhosis, is 85%. So there is no big difference except for those who have lower albumin level. When we look to the side effects, about 22% of our patients have side effects. Most of these side effects was seen in the first week, and after that they dropped. And also most of this side effect was a flu-like syndrome, and we have some cases of anemia and rashes, but this also is not big manifested like the flu-like syndrome. Of course, we started another treatment program for sofosbuvir and semibrivir in April this year, and we will start sofosbuvir-pegylated in this next month, but this is the data that we have for the triple therapy. In conclusion, this report is a real-life national-wide treatment campaign using sofosbuvir-pegylated interferon-ribavirin in patients with advanced fibrosis, because all our patients are F3 and F4 when we started the treatment, and it showed a high sustained virological rate. Lower serum albumin level is the only predictor of no sustained virological response. More real-life data for both the triple therapy and dual therapy will be available in the next meeting, and thank you very much.
Thank you. Are there any questions from the audience?
If I may, can I ask a quick question, Gamal, while you're coming back? Firstly, congratulations. That's a phenomenal study, and organising and tracking those patients is extraordinarily impressive. You had a handful of deaths. Any factors that predicted? Was the low albumin associated with mortality and morbidity?
I have only one mortality in this group, and this mortality is due to bleeding esophageal varices. I don't make a correlation, but it's only one patient, so I cannot look for that.
And the decompensated, was there anything coming out?
We didn't start decompensated treatment by interferon. We said that the interferon, the triple therapy, will be for those who are compensated cirrhotic. We didn't give decompensated cirrhotic interferon, but we gave them dual therapy, sofosbuvir and ribavirin, and we are giving some of them now sofosbuvir and simibrivir. But we said that those who would receive interferon must be compensated cirrhotic.
There's a mic. There's a mic.
Congratulations for all this Egyptian plan, which is a model. One question, according to practice, the patient has to come back in the clinics to hospitals for the treatment in which each month, or so then compliance is 100%?
Yes. For those who are receiving interferon, they have to come weekly for the first month, and then they come every month. But for those who are receiving sofosbuvir and ribavirin, they are coming every month. And also, we are now thinking about looking for sustained virological response 4 weeks rather than 12 weeks, because we think that 4 weeks is the same as 12 weeks. And when you give the patient a long distance, saying to him, come to me after 12 weeks, maybe the compliance is not like when you said to him, come to me after 4 weeks. So we'll start to involve the sustained virological response 4 weeks in our study, because we noticed that we have a missing data in some of our patients because they didn't come after 12 weeks.
Gamal, thank you very much indeed.